Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 265 of our pharmacotherapy series, which majors in urinary tract infections. The first question reads, ROD, a 22-year-old woman, complains of urinary frequency and painful urination, which have developed during the past 4 to 5 days. Urinalysis reveals 10 to 15 WBC per LPF, but no bacteria are seen on a gram stain of the urine. So my question to you is, what is a reasonable assessment of ROD's clinical presentation? Acute urethral syndrome is defined as symptoms consistent with lower UTI but with no organisms evident on gram stain or culture. The lack of detectable pathogens may mean that the urine specimen is sterile or that the concentration of the organisms in the urine sample is low. Patients with these symptoms still may have a UTI even though the voided urine is sterile or contains less than 10^5 microorganisms per milliliter. The causative organisms and the pathogenesis of infection in these cases are the same as for lower UTI. Other organisms that can cause urethritis in this setting, especially in the presence of pyuria, are Chlamydia trachomatis, Neisseria gonorrhoeae, and Trichomonas vaginalis. Conversely, in patients with acute urethral syndrome without pyuria, non-infectious causes of urethritis are common and should be sought. Because ROD is symptomatic, has 10 to 15 WBC per low-power field in her urine, and no bacteria on gram stain, infection with Chlamydia trachomatis or some other more atypical pathogen is likely. Interstitial cystitis, also known as painful bladder syndrome or bladder pain syndrome, is a chronic clinical syndrome characterized by bladder or pelvic pain and urinary frequency or urgency. Although the exact cause of interstitial cystitis is not known, it is apparently not an infection-related disorder and does not respond to antibiotic therapy. The clinical presentation of interstitial cystitis is very similar to that of symptomatic bacteriuria, but absence of pyuria is a key difference. Interstitial cystitis should be suspected in patients with clinical findings suggestive of lower UTI but who do not manifest pyuria and who have not responded to previous empiric antibiotic therapy. No antibiotics should be administered without further diagnostic evaluation. The next question reads, should ROD be treated with antibiotics? A double-blind, placebo-controlled study evaluated the use of doxycycline 100 mg twice a day in patients with urinary tract infection and low bacterial counts. Clinical cure of bacteriuria and pyuria was significantly greater in the doxycycline-treated group, but doxycycline did not reduce symptoms in patients without pyuria. because Escherichia coli, other gram-negative bacteria, and Chlamydia trachomatis are the usual causes of acute urethral syndrome, and antibiotics such as doxycycline with activity against chlamydia is a reasonable initial treatment for patients such as ROD presenting with urinary tract symptoms without bacteriuria and with puria. All tetracyclines and sulfonamides with or without trimethoprim also are likely to be effective in such patients, but doxycycline has been best studied to date. Of the fluoroquinolones, newer agents, such as levofloxacin, offer promise as alternatives to doxycycline but have not been well studied in this setting. Azithromycin as a single dose also has a major role in treating chlamydial infections. Prolonged therapy of 2 to 4 weeks in duration and treatment of sexual partners may be required to prevent reinfection through intercourse. Prolonged therapy is appropriate if the patient has a history consistent with chlamydia urethritis, a sexual partner with recent urethritis, a recent new sexual partner, a gradual, rather than abrupt, onset of symptoms that has occurred during a period of days, as in ROD, and no hematuria. Patients without such a history can be treated with a short course of antibiotics as any other patient with a lower urinary tract infection. The next question reads, POM, an alert, 70-year-old woman with chest pain, was hospitalized to rule out acute myocardial infarction. This is her third hospitalization for chest pain in the past 6 months. A urinary catheter was temporarily placed as part of her routine medical care. 2 days after admission, she complained of burning on urination and bladder pain. TMPSMX double strength, 1 tablet twice daily was ordered after microscopic examination of the urine indicated a urinary tract infection. Was this empiric therapy appropriate? Hospital-acquired, or nosocomial, urinary tract infections occur in about 1/2 patients per year and most are associated with the use of indwelling bladder catheters. Approximately 10% to 30% of catheterized patients exhibit infection. Complications of catheter-associated urinary tract infection are significant. Nosocomial urinary tract infections are the source of up to 15% of all nosocomial bloodstream infections, occurring in about 4% of all catheterized patients. 23. The associated mortality rate is approximately 15%. Nosocomial urinary tract infection also prolongs hospitalization by an average of 2.5 days and costs an additional $600 to $700. Prevention is the best way to manage nosocomial urinary tract infection, but antibiotic treatment is usually initiated in hospitalized patients who exhibit urinary tract infection symptoms. The susceptibility of hospital-acquired pathogens to antimicrobial agents differs from community-acquired bacteria, and these susceptibilities frequently vary from one hospital to another. Therefore, the microbiology department of a particular hospital should be consulted to determine current trends in the antibiotic susceptibility of bacteria acquired in that setting. In general, Escherichia coli is still the predominant urinary tract pathogen. An increased proportion of infections is caused, however, by other gram-negative bacteria such as Proteus and Pseudomonas, gram-positive pathogens such as Staphylococcus and Enterococcus, and yeast, e.g., Candida. Repeated courses of antibiotic therapy, anatomic defects of the urinary tract, old age, increased length of hospital stay, and repeated hospital admissions are associated with a higher incidence of infection with antibiotic-resistant organisms. Pseudomonas, Proteus, Providencia, Morganella, Klebsiella, Enterobacter, Citrobacter, and Serratia are particularly difficult to eradicate because they usually are less susceptible to commonly used antimicrobial agents. POM is elderly, hospitalized, and has been repeatedly exposed to potentially resistant organisms during her previous hospitalizations. Oral fluoroquinolones are most commonly used as empiric therapy in this setting because of the greater activity against potentially resistant pathogens compared to TMPSMX. However, TMPSMX is an acceptable empirical therapy in POM as long as her clinical and laboratory data are appropriately monitored. Cultures of POM's urine should be performed and, once culture and sensitivity test results are known, therapy promptly changed according to susceptibility reports. To achieve the most cost-effective therapy, oral agents should be administered to all patients capable of taking medications by mouth unless the isolated pathogens are resistant to oral medications, or underlying GI dysfunction makes adequate absorption of oral antibiotics questionable. The recommended duration of antibiotic therapy for patients such as POM, who present with mild to moderate symptoms, is 5 to 7 days. Patients who do not respond promptly to treatment may be treated for a total of 10 to 14 days. The next question reads, if POM had additional symptoms of fever, chills, flank pain, and vomiting, how would her treatment differ? In seriously ill patients with possible sepsis, broad-spectrum parenteral antibiotics with activity against Pseudomonas aeruginosa are usually preferred as initial therapy. Suitable antibiotic choices include anti-pseudomonal cephalosporins, e.g., ceftazidime, cefepime, extended-spectrum penicillins, e.g., piperacillin tazobactam, carbapenems, such as imipenem, cilastatin, meropenem, IV fluoroquinolones, e.g., ciprofloxacin, levofloxacin, and aztreonam. These antibiotics are at least as effective as the aminoglycosides and lack the ototoxic and nephrotoxic potential. However, these fluoroquinolone and beta-lactam agents are more costly and associated with the emergence of resistant organisms and superinfection. In general, anti-pseudomonal beta-lactam antibiotics remain the drugs of choice for nosocomial urologic sepsis. Although combination therapy may be useful initially in neutropenic patients with urologic sepsis, it should be narrowed to single-agent therapy once culture results are available. The recommended duration of antibiotic therapy in seriously ill patients is 10 to 14 days. The next question reads, JAW, an 18-year-old woman, was hospitalized after a diving accident that resulted in a spinal cord injury with paralysis. Included among several initial interventions was insertion of an indwelling catheter with a closed drainage system because of bladder incontinence. 2 weeks after admission to the hospital, JAW has developed asymptomatic bacteriuria. So my question to you is, should this be treated? A systemic antibiotic selected specifically for the infecting organism will temporarily result in sterile urine. Reinfection, often by a resistant organism, occurs in 30% to 50% of these cases if closed drainage catheterization is continued during therapy. For this reason, it generally is recommended that systemic antimicrobial therapy be initiated after or just before catheter removal. Because long-term catheterization is necessary in many patients and because bacteriuria is an inevitable consequence, it is often recommended that asymptomatic patients, such as JAW, be left untreated to avoid the complications of recolonization and potential infection with resistant organisms. Therapy must be started, however, if fever, flank pain, or other symptoms indicative of an actual urinary tract infection develop. The next question reads, is systemic antimicrobial prophylaxis useful for JAW? The benefits of systemic antibiotics in preventing catheter-induced urinary tract infection are not clear. Studies using closed drainage systems with diligent catheter care indicate that systemic antibiotics decrease the daily and overall incidence of infection in patients with sterile urines before catheterization. The preventive effect of antimicrobials is greatest for short-term catheterizations or during the first 4 to 7 days of long-term catheterization. Thereafter, the rate of infection increases. Although the overall infection rate remains lower than in untreated patients, the emergence of resistant organisms is significant. Therefore, in deciding to use systemic antimicrobials, it is important to consider the patient's underlying diseases, risk factors, probable duration of catheterization, and potential complications of drug toxicity or resistant organisms that can result from the chronic use of antimicrobials. Because long-term catheterization is anticipated for JAW, antimicrobial prophylaxis for JAW is not recommended. The next question reads, JAW eventually recovers urinary continence and the catheter is able to be removed. However, 2 days after removal of the catheter, she still has asymptomatic bacteriuria. How should she be managed? Because asymptomatic bacteriuria in patients with urinary catheters is very common, approximately 25% with short-term catheterization and virtually 100% long-term, but is associated with few complications, antibiotic therapy for asymptomatic bacteriuria is not recommended as long as the catheter remains in place. However, antibiotic treatment may be considered in asymptomatic women with catheter-acquired bacteriuria that persists beyond 48 hours after catheter removal. Such patients may be treated with either a single large dose or a 3-day regimen of TMP/SMX, even if the patient is asymptomatic. Older women that is above 65 years probably should be treated with a 10-day course, however, the optimal duration in this age group is unknown. Whether these same treatment regimens are advisable in male patients requires further study. The next question reads, DOG, a 60-year-old man, experienced his first urinary tract infection at age 40, with symptoms of frequency, dysuria, nocturia, perineal pain, fever and chills but no flank pain. Acute prostatitis was diagnosed. Escherichia coli was cultured from the urine, and treatment with a sulfonamide was successful. After 12 asymptomatic years, acute prostatitis caused by Escherichia coli recurred and again responded to sulfonamide therapy. 2 more Escherichia coli infections that responded to sulfonamide therapy occurred during the next 8 years. Why were sulfonamides appropriate treatment for DOG's repeated acute episodes of bacterial prostatitis? Most antibacterial drugs appropriate for urinary tract infection, including sulfonamides, can be used to treat acute bacterial prostatitis because the diffuse, intense inflammation of the prostate gland allows many drugs to readily penetrate into the prostatic fluid and tissues. Antimicrobial therapy should be continued for at least 2 to 4 weeks to prevent the development of chronic prostatitis. The next question reads, taking into account the pathophysiology of prostatitis, what would be a reasonable choice of therapy for DOG should he have future recurrences of prostatitis? In addition to antibiotics, other supportive measures may provide symptomatic relief to patients with acute bacterial prostatitis. These measures include liberal hydration, non-steroidal anti-inflammatory drugs for pain relief, sitz baths, and stool softeners. In retrospect, sulfonamides were appropriate for DOG because they effectively treated his infections. Other options, particularly the fluoroquinolones, would also have been appropriate in the treatment of DOG's episodes of acute prostatitis. Most antibiotics that are acidic do not readily cross the prostatic epithelium into the alkaline prostatic fluid except in the presence of acute inflammation. Theoretically, the high alkalinity of prostatic fluids should impair the diffusion of trimethoprim and enhance the diffusion of tetracyclines, certain sulfonamides, and macrolide antibiotics, such as erythromycin. Nevertheless, TMPSMX historically has the best documented cure rates in the treatment of acute and chronic bacterial prostatitis. Long-term therapy of chronic bacterial prostatitis with TMPSMX for 4 to 16 weeks is associated with a cure rate of 32% to 71%, which significantly exceeds the cure rate associated with short-term therapy of 2 or fewer weeks. The fluoroquinolones are alternatives to TMPSMX and are now considered by many to be the agents of choice for the treatment of prostatitis. A number of studies have documented bacteriologic cure in 80% to 90% of patients treated with norfloxacin, ciprofloxacin, or levofloxacin for 4 to 12 weeks, rates comparable to or substantially higher than those achieved with TMPSMX. The fluoroquinolones have an important role in the treatment of prostatitis owing to their bactericidal activity against common pathogens and excellent penetration into prostatic tissues and fluid. The fluoroquinolones are often used as initial empiric therapy of prostatitis and are also excellent alternatives to other agents in patients who are unresponsive or intolerant to conventional therapy, or in those infected with resistant organisms. Fluoroquinolones also have been used for chronic suppressive therapy, 1/2 normal doses, in patients who relapse after conventional treatment. DOG should be treated with TMPSMX for a minimum of 6 weeks. Some authorities recommend a 2 to 3 month total course of therapy. If an adequate trial of TMPSMX is unsuccessful, fluoroquinolone therapy can be used. Alternatively, a fluoroquinolone could be used as initial therapy for this or future episodes. If DOG continues to experience recurrent infections after a trial of fluoroquinolone therapy, chronic low-dose treatment with TMPSMX, fluoroquinolones, or nitrofurantoin can alleviate the symptoms of episodic bladder infection associated with chronic bacterial prostatitis. Infections eventually recur with greater frequency in most of these patients. Chronic, low-dose antibacterial therapy sterilizes the bladder, alleviates symptoms, confines bacteria to the prostate, and prevents infection of and damage to the rest of the urinary tract. Chronic bacterial prostatitis is one of the few indications for continuous antibiotic therapy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 266.